I think with fatigue management, this is where I really pull out my internal medicine hat because I found that it's so multifactorial, right? I think there is no doubt that for patients who are on prolonged cytotoxic therapy, whether it's conventional chemotherapy or antibody-drug conjugate, that there is a fatigue element that is progressive. If it is that mostly progressive fatigue that we're really convinced is the drug related, right? Like we've looked for coexisting sleep disorders and we've fixed mood disorders and we've minimized medications that might be making them tired. I'm really convinced that it is our cancer therapies. I've really found that dose reduction is the most helpful thing. And this is where I find myself really trying to assure patients that when we look at follow-up results of these studies, even patients who had dose reduction in a purposeful way, right? Because we know their toxicity was significant, that they still benefit from the drug. So like we were talking about earlier, this is another education point that you really have to walk patients through. I also wonder if many of my patients minimize the degree of their fatigue because they don't want me to cut back on the chemotherapy dose. And so this is open dialogue, right? And by the time we're recommending these medications to patients, I think we probably have an established relationship that we're talking through all of these things. But I feel like that is probably the most meaningful thing I do is say, you know, we're treating your cancer so you can be here, you can be living, but I want you living that life. And if your fatigue is a hindrance to you living your life, then we've got to do something about it. Unfortunately, it's been hard because I feel like many of our patients are looking for a quick fix in that fatigue, and it's usually not that kind of toxicity.
As you mentioned, it's multifactorial, and there could be a psychosomatic component to that too. You know, a lot of times, especially for my patients with advanced stages of lung cancer, even if they're relatively asymptomatic, even after starting therapies, I'm referring them to our palliative med group. I think they play an integral part in terms of the patient care. And they can help assess the fatigue, help work on the fatigue, but maybe even touch on some of these social aspects that might be contributing. You know, this is a life-changing diagnosis. It impacts not only their personal lives, their professional lives, and that can be that emotional burden that these patients are carrying can also be mass as fatigued.
Yeah, absolutely. And I found myself doing the same, actually. I know there's like good data out of the lung cancer world, actually, originally, that early incorporation of PalMed involvement helps patients live longer. And I think there really is something to that. And, you know, I have not been brave enough on my own to think about things like stimulants for fatigue.
Same.
Occasionally, our palliative medicine physicians, I think, do think about stimulants. And we've had some success, but I think you have to be very cautious about what patients you recommend for what drugs. And honestly, treating mood disorders and treating like all of the complicated emotions that go around this cancer diagnosis actually helps a lot with fatigue, I feel like. So yeah, going back to, you know, using medicines that have multiple purposes, right? So if we can get a medicine that is good for mood and for pain, that's a great solution. And it often helps patients with their fatigue element.